We're here today to talk about clear aligner therapy. So, title is the preferred orthodontic solution. And the reason why we're going to be talking about this today is because, as many of you know, we want to look for as many streams of income that we can have in our office without that huge overhead and without a lot of hassle. So that's really what this webinar is going to be focused on: the use of clear aligner therapy to increase the profits in your office, while at the same time not increasing the overhead as much. I want to thank DenMat obviously for putting on this webinar and their continued support for education in the dental field. DenMat is, as many of you know, located here in California, so it's a U.S. company. It's always determined to innovating products and being minimally invasive. So many of you know DenMat from Veneers, so they're the makers of Veneers, and their minimally invasive dentistry has actually transcended, which now includes clear aligner therapy. So we're going to go ahead and get started a little bit with the common orthodontic problems that can be solved with clear aligners. So with clear aligners or regular orthodontics, we can solve problems with crowding, excessive spacing, cross bites, open bites, overbite or deep bites, underbite, overjet, and also abnormal eruptions. But just because we can solve all these problems with clear aligners, or just because we can solve all these with traditional orthodontics, doesn't mean that we have to treat all these cases. So again, the webinar is going to be focused on those cases that you can treat at your office if you're not an orthodontist. Maybe those simple alignment cases, a little bit of crowding, a little bit of spacing. But obviously, it's not my goal to try to convince you to treat a patient with a severe crossbite or an underbite, or patients that have just really severe orthodontic problems. As always, those, I believe, in my practice, they should be referred out to the orthodontist. But if a patient comes in and they're asking to get their teeth straightened a little bit, or to fix a little bit of spacing, well, then we can make sure that we can offer that to our patients in a very successful manner. One of the main reasons why we use clear aligners in our office is actually to prepare our patients to receive restorative work, whether that's Veneers or whether that's restorations with implants. So I'm going to show you a case to start of a very young lady. She's 23 years old. She came to our office because she was actually told that there was really not much that they could do in her case, because she has some laterals that were missing congenitally. So what can we do with a case like this? Well, when we see this, we know that it's going to be pretty complex to treat something like this without moving teeth. So the first thing that we did was trim implant this by measuring how much space we actually had in that arch to see if we were actually going to be able to restore those two laterals that were missing. What we ended up doing is we measured, and we saw that we had enough space to where we could actually close that gap in the middle, or those gaps in distal and mesial of the canines, to allow us to give us a little bit more space and actually in the future implant two laterals, so place two implants in those laterals and then restore the smile. So when we sent this case to be trim implant with those instructions in mind, this is the rendering that we got back from DenMat. So DenMat told us, you know what, we can do this case. This is how long it's going to take, and this is the expected results. So we can see that we have enough space now to where we're going to be able to place those two implants, and we're going to be able to restore that those two missing teeth just by moving a little bit of or closing those diastemas, closing those spaces that we had there. Now we can make that space to finally restore that patient. To talk a little bit about the classifications of malocclusion, we know this from dental school. We have a class 1 malocclusion, which just means that the mesial buccal cusp of the first upper molar sits on the groove of the first lower molar, okay? And the upper canine is going to sit behind the lower canine. So this is very typical. This is probably the easiest case to solve whenever we have a little bit of malocclusion, depending on how much grouting or spacing we have, because we see that the molars are actually in a perfect spot, and so are the canines. So it's going to be the easiest of the three classifications to solve. Moving a little bit forward, we see that we have a class 2 malocclusion, and this is actually when we just shift the entire upper arch forward. So that means that the upper arch is going to be sitting in front of the lower arch, as opposed to where we have a class 1 malocclusion where we have a much better intercuspal relation. If we go to class 3, now it's going to be the opposite, where we have that upper arch actually sitting behind that lower arch. So this is called an underbite too. So these cases are going to be a little bit more difficult to treat, especially because most times this is going to be a skeletal problem. So definitely not going to be something that I would want to attempt to try to solve with clear aligners. So what cases can we solve with clear aligners? What cases should we solve with clear aligners? And what can we actually offer to our patients? Well, actually, it's going to be the vast majority of the cases that walk into our office. So when we have crowding, so crowding just means that we have insufficient space for the teeth completely in the mouth. So if we see a case like this where we have about less than 3 millimeters of crowding, this is actually going to be a case that's going to be very successfully completed with clear aligners. So by using OrthoClear, we can actually adjust the position or better the position of all those teeth to where that patient is actually going to have a much nicer smile, that's going to be a lot more symmetrical and a lot more pleasing. Spacing. So this is also something that's very common, and usually spacing or diastemas are some of the easiest cases to solve, because it really just requires to move everything back to the original position. Usually when we have spacing, it's because either we had a habit of either a patient used to be sucking their thumb or something that was pushing their teeth forward. It often occurs more likely in the top arch, but when we have that spacing, it's actually becomes fairly simple with clear aligners to move those teeth back to the position where they were supposed to be at. We also have patients that have overjet. So this is mainly seen in patients with class 2 malocclusion. So when we have overjet or the protrusion of the anterior teeth, if we have a discrepancy of about 2 millimeters, that's going to be a fairly simple case to solve with clear aligners, to where we can actually move everything back, shift a little bit of those, shift those teeth just a little bit, maybe create a little bit of space with interproximal reduction, but we're going to be able to fix this with some clear aligners. We also have deep bite. So deep bite just means that we have an excessive vertical overlap. So the top teeth are going to be covering the lower teeth, and what's going to happen here is that it's not going to be very aesthetic when the patient smiles, because in order to have a harmonious smile, we want to be able to have enough white and pink aesthetics. So that means that if the lower arch is only completely pink, well, that's just not going to be something that's going to be aesthetically pleasing. So when we have cases with a deep bite that we have about 2 millimeters of overlap, again, that's going to be a good case to choose in our office to solve with clear aligners. So when we're talking about these cases, what is it that we have to know to send to the lab, or what do we have to know to be able to communicate properly with the lab and also with the patient? Well, this is some clear aligner terminology. The first thing we think of is alignment, which is in the name. So alignment, it just means that we're gonna be pretty much putting every tooth where it belongs in a spatial manner. We have angulation, extrusion, inclination, interproximal contacts, interproximal reduction, and we're going to go over all of these one by one. We also have expansion, distalization, torque, translation, tipping, and intrusion. So these are the terms that we have to know, because this is how we're going to be communicating with the lab. if we have a tooth that needs to be translated or moved, we want to make sure that we put that we want that tooth to be translated. If we just want a little bit of tipping or extrusions or inclinations or intrusions, so anything that we want the lab to do based on the treatment plan that they're going to give us, it has to be always be based on what we're telling them. So we're the doctors, we're the ones that are actually going to be that we're going to be leading the treatment plan. The lab is really just there to give us a great 3D rendering and a great treatment plan. But we are the ones that are behind the whole treatment plan. So we have to be able to understand these terms that are used in the clear aligner. So let's start with the first one, which is crown tipping. So crown tipping just means that we're tilting the crown without moving the apex of the root. So this is probably one of the simplest movements in clear aligner therapy, where we can just move the crown, but again, the root stays by itself. So this is usually done whenever we have a tooth that's pretty much either shifted to one side or shifted to the other side, but we don't want to move the root. So again, it's something that's fairly simple to move because we're just focusing on moving the crown itself. Next, we have root tipping. So root tipping is going to be the opposite of crown tipping. Root tipping just means that we're tilting the root of the tooth without moving the crown. So this is going to be the opposite. Now our point of fulcrum is actually going to be on the crown instead of the root. So when we do this movement, we're actually moving the tooth a little bit, the tooth root either mesial or distal. So when do we do this? When can we do some root tipping? Well, if we're thinking of placing an implant in an area where we have maybe not enough space at the apex, where we can take advantage of clear aligners to be able to tip that root out of the way and move it a little bit more to the adjacent teeth, so that when we actually do the implant, when we place the implant can be placed correctly, and it's going to be at least 1.5 millimeters away from that root. So that means that we're going to be able to safely place an implant without damaging that tooth. Next, we have translation. So translation is the movement of the entire tooth along the occlusal plane, but this is going to be without changing the orientation of the long axis. So pretty much this is what most people think of whenever thinking about orthodontics or orthodontic movements. We're talking about moving the entire tooth either one way or the other. So when do we do this? So in the case that we had in the first case that I showed you, where we're going to be placing those implants, we wanted to move the entire tooth, not just tipping of the crown, because if we did the tipping of the crown, the root of the tooth was going to remain in the place where the implant was going to be placed. So whenever we want to move a tooth completely, this is called translation. So we want to be sure to be using this terminology, because this is what's going to tell the lab exactly what they need to do in order to move that tooth. So whenever we're doing translation, we usually want to have attachments. So those attachments, what we're going to be talking about a little bit later, are actually going to be little buttons that attach to or are bonded to the tooth itself and with composite, and that's going to help that translation or that movement of the entire tooth either one way or the other based on what your treatment plan is. We also have proclination. So proclination is going to be tilting of the anterior teeth forward. So this is just going to be like crown tipping, where we are actually tipping the crown instead of mesial distal. With proclination, we're actually tilting the teeth forward. So if we don't have enough space for a restoration, maybe in the lowers, or if if the arch is actually very square on the top, instead of having that nice curvature, then we can go ahead and take proclination to move those teeth forward to help us move them better in space, and this is going to allow for a nicer smile. We can also do something called alveolar expansion. So the alveolar expansion is going to be expanding the dental arch by way of moving teeth. But this is not the same as skeletal expansion. So skeletal expansion is something that can be done in young adults or teenagers. So before we have that fusion of the suture that's actually going to be giving us that space to move. So whenever we have alveolar expansion, we're actually using the teeth that are embedded in the dental arch, and by moving them slowly, we can actually widen that area. But this is not a skeletal expansion. This is just on the alveolar. It's an alveolar expansion. So this is also something that's fairly simple to do with clear aligners. It does take a while, but it's actually something that has very, very good results. So whenever a patient, again, has maybe like a square arch and we want to expand that, this is something that can definitely be done with clear aligners. Next, we're going to be talking about torque. So torque is probably one of the hardest things to explain. I hope that this slide helps me explain a little bit better. So what torque is that we're actually moving the crown either lingual or labially, and this rotation is going to rotate the root in the opposite way. So the rotation is actually anchored at the center of the tooth, rather than it being either at the crown or the root, like we saw with tipping. With torque, the center is actually on the center of the tooth itself along the axis. So whenever we do some torque, this is what's actually going to happen to the tooth. So this is probably one of the most difficult movements that we can have when we're talking about clear aligner therapy, just because it's really difficult to make that center of the tooth be where everything's going to be anchored at. But it can still be done up to about 10 degrees without a problem. Next, we have rotation. So rotation is also something that's fairly common, especially when a patient comes in for asking for clear aligners. I find that most of the time they're just concerned about a couple teeth that are just not rotated correctly. They're not where they're supposed to be at. And just with a little bit of clear aligner therapy, we can definitely rotate this. A good starter case would be something that's less than 10 degrees that needs to be rotated. That doesn't mean that you can't do something that's a little bit longer, a little bit more aggressive. But a good tip is to make sure that we take photos and that we see exactly where that tooth is going to end up. So if we see this tooth right here, the problem with this tooth is also going to be rotation, right? So this tooth is completely rotated, but we can go ahead and put it back into that arch. But before we do that, we must have interproximal space. So either we create space by doing some interproximal reduction, or in this case, we can see that that patient actually has a mesial distal filling, occlusal distal filling on that first premolar, and a mesial occlusal filling on that second premolar. So we can take advantage of that by actually stripping that part and then at the end redoing that filling. Or if we look at that molar, we can see that that's actually a crown. So we could easily, we could just remove that crown, put our tooth back in the arch where it's supposed to be by using the powers of clear aligners and rotation. And then at the end, we can replace that crown to where it's going to be in a very nice position where now all our teeth are going to be aligned. Distalization is also something that can be done, which is what we saw in that first case. Distalization just means that we're going to be moving those teeth away from the bin line. So they're going to be going more posteriorly. And the opposite of distalization is going to be mesialization. So mesialization just means that we're going to be moving the teeth forward. So again, in that first case that we saw that the two centrals were actually mesialized to close that position, to close that diastema. Now moving into a little bit more difficult movements, especially more unpredictable, we're going to talk about intrusion. So intrusion is when a tooth is sticking pretty much out of the arch. It's a little bit too high. So what we want to do is move that tooth apically. So again, this is something that's fairly difficult to do. It always requires attachments. where I find that if a tooth does not have an attachment for intrusion or for even extrusion, it's going to be very difficult to achieve any tooth movement at all. And that's just because the forces that are going to be applied are a lot more difficult. Of course, if you apply too much force when you're doing intrusion, then what's going to happen is that you can actually have external root reabsorption, which is something that we definitely don't want to have. So whenever we're doing movements that are a little too harsh, then that's going to cause some damage to the tooth. So we want to make sure that we're using the right materials. We want to make sure that we're using clear aligners in the right way with FDA clearance. That way we can avoid all these problems where the patient we can actually do a harm to a patient rather than doing them a benefit. So intrusion, again, just means moving the tooth apically or more towards the root. Extrusion is going to be the opposite. So it's going to be moving the tooth coronally. So again, we can achieve about 1 millimeter of movement with extrusion and intrusion. But again, this is going to be difficult without the use of accessories. Whenever we have a tooth that needs to be extruded, so we're not talking about a tooth that's actually going to be retained, like a retained canine or a retained lateral. Those are going to be those are definitely going to be that can be moved, but with accessories like rubber bands or chains. It's going to be something that's going to be a little bit more complex, and usually that's best done with traditional orthodontics. When we're talking about clear aligner therapy and we want some extrusion, we're talking about teeth that are just not in the same occlusal plane. So if we want to move a tooth a little bit more coronally, up to 1 millimeter, that's definitely something that can be done with clear aligners. That tooth will have an attachment in order to help us pull it up. And we have to make sure that whenever we're treating the patient, that we're taking a look at it consistently to make sure that that tooth is actually moving and that the aligner snaps on that attachment that we place on that tooth. Okay, so now we talked a little bit about the movements that we can complete with clear aligners. Let's talk about the 5 steps that we need for case completion. So the first step, as always, is going to be the patient needs to accept that treatment plan. Next, we can talk about initial records that we're going to be using to send to the lab. Then we're going to be looking at the treatment setup that we get back from the lab. We're going to talk a little bit about aligner manufacturing, and then finally delivery and how we actually give those to the patient, how we deliver those to the patient, and what we tell our patient. So let's go ahead and start with the first one, which is going to be the patient accepting that treatment. So how do we get patients to accept treatment? How do we get patients to be asking for clear aligner therapy? And what is it that we do in our office to make sure that we keep those patients coming back? Well, patient acceptance has 2 parts. It's either going to start with external marketing or it's going to start with internal marketing. So external marketing, that's just marketing that you do to patients that have never heard of your office. So either through advertisement on ads, billboards, online, whatever it is, but it's going to be something that that patient would have not known about your office without you actually posting that ad. So for internal marketing, this is actually one of my favorites, which is, you're going to be using your office space to promote your treatments to your existing patient base. So this is going to be with patient photos. We're going to be using a LumiSmile app, which is something that we do on every patient that comes into our office, and definitely team communication. We want to make sure that your team is communicating to the patient, that your assistants, whenever they're taking x-rays, or whenever you're talking to the patient about anything that it is, if the patient says something about their smile, about them having maybe being unhappy with their smile, well, we want those assistants to know that we offer clear aligner therapy. We want them to be able to communicate that to the patient. So then when we go in the room to talk to the patient, they already know a little bit about it, and it just makes the conversation a lot easier to have. So communication is definitely going to be key. But when we're talking about external marketing, you see there that I have something called the Smile Discovery Program, which is something that DenMat has. So DenMat Smile Discovery Program, it's actually a great program to get that external factor taken care of for your office. So this is based on ads on social media that DenMat actually makes for you. You can decide what you want to advertise, and it's 1 to 3 months, whether it's lumineers, implants, clear aligners, whatever ad that it is that you want to run, they'll actually make it for you and they'll run it for you. And that's really where we get most of our patients, our new patients from our office, other than friends and family referrals. It's really through DenMat Smile Discovery Program. So it's a way to advertise outside of your office to bring new patients in. Now, when that patient comes in, the first thing that we do is that we take a portrait photo of them. So by doing this portrait photo that we send to the lab and something called LumiSmile with also with DenMat, in about 20 minutes, DenMat gives us a digital smile design that we can actually show our patients. So all these patients right here have a digital smile design, and that digital smile design can include either lumineers, whitening, or orthoclear. So we can show that to our patient. We can decide which photos we show to them, and that's something that's going to help us offer our treatment to them in a very consistent manner, and it's actually going to help them visualize it. So it's something that's easy for them to understand. It makes it a lot easier for them to accept treatment plan, because now they can see exactly what the results might end up looking like. Okay, so the next step is going to be taking the initial records. So initial records include intraoral scan or a regular traditional PVS impression. We want to have clinical photos, radiographs, and finally the prescription form. So the first thing that we have to do is we want to make sure that we capture that arch so we can send it to the lab. So I prefer to use a scanner just because it's a lot more accurate. But again, you can still use heavy and light body impressions and send that to the lab. But the first thing that we do again is we scan the patient, we scan the full arch, and by scanning the full arch, we're able to send that to the labs for them to make us clear aligners based on our recommendations. Some common errors that we need to be able to avoid are making sure that we have enough information that's scanned. So the most common error is going to be the gingival is not scanned all the way, or that we have some holes that need to be filled. Now, the problem with this is that whenever we have a scanner, there's actually a setting there that says fill holes on most scanners. And what ends up happening is that we might think that we have a complete scan, but in reality, there's going to be a lot of data that's missing. So we want to make sure that we have a good scan or a good impression to make sure that all those teeth are copied, because remember, this is going to be the basis or the foundation of it's going to be the foundation of all our clear aligners, of our ortho clear aligners after we get them back. So if we don't have a good foundation, then there's no way that our treatment is gonna go forward nicely. Next, we want to have clinical photos, so high quality clinical photos. So this is the setup that we want to send to the lab. We want to have these 5 intraoral photos and those 3 extraoral photos. So we want to have retracted inocclusion, so make sure that the patient is biting down all the way, because this is going to be super important whenever we're treatment planning. We want to have it from the laterals and also one that's straight on. We also want to have a good occlusal shot of both the upper and the lower arch. So we can see that we have a little bit of shifting that needs to be done in those teeth, and those 8 and 9 teeth, especially number 9. So without this photo, we wouldn't really be able to tell everything that all the information that we have, we wouldn't be able to communicate that to the lab. We want to have those 3 photos also in the bottom where we have the patient smiling, we want to have the patient at rest, and we also want to have a profile at rest. So this is all going to help the lab make us a good treatment plan and something that the patient is going to be happy. Next, radiograph. So we want to make sure that we take x-rays. This is more than anything is for attachments. So whenever we have an attachment, that attachment is actually going to go on the tooth itself. But if a tooth has a crown, like a ceramic crown, that's really not going to be something that's going to show up easily on the impression or on the scan all the time. So radiographs are going to help us with that. And then in the prescription form, there's actually going to be a space where we can tell the lab where not to put those attachments. So after we have all these records, the next thing is going to be the prescription form. So this is going to be the form that you actually fill out to send to the lab. And we're going to go over it really quick, just because I think it's something that's super important, because this is again, the foundation of how your clear aligners are going to be made. So obviously we're going to put our office information, the patient information, and age, and then we're going to see what it is that we want to do. What trim implant do we want to do? We want to do both arches or just one arch? You can see that there's a little box right there that says allow IPR. So IPR is interproximal reduction. And we're going to talk a little bit about that later on during the presentation, but this pretty much means if you're going to be able to do some, if you need some spacing to be done, this is something that you're going to have to be done, that you're going to have to do at your office at the time that you deliver those OrthoClear aligners. Next, we want to specify where attachments are excluded. So again, this is going to be on teeth that probably have crowns. So we want to make sure that we put that attachments are going to be excluded there, because those cannot be easily bonded to either porcelain or ceramic. Next, we want to specify if we want any teeth that we don't want to have moved. So if a patient has implants, a very common question is, can we use OrthoClear on patients that have implants? And the answer is yes. Yes, you can use them, but remember, those implants are not going to move. So we do not want those teeth to be moved. We want to make sure that we tell the lab this tooth cannot be moved because it has an implant. Next, the midline. So we either want to maintain it or we want to move it. So depending on what we want to do, this is the place where we put it. Again, with those photographs that we took, those photographs are actually what's going to help the lab see if this is something that's doable, and it's going to help us also trim implant a little bit better. We want to have the anterior posterior relation, so we can either improve the canine relationship, or we can maintain it or leave it. That's again going to be depending on what we want. Next is going to be the gingival margin scallop. So the scallop is actually where the OrthoClear aligners are going to be trimmed at. So you can see that we have two different spots. One is going to be following that gingival contour, and the other one is just going to be a straight standard scallop. So what I recommend doing is actually going to have most of the time a straight scallop. So we don't want to do that gingival scallop on cases that need a lot of retention, because we see that there's a 2 millimeter, whenever we have a 2 millimeter straight gingival margin design, that's going to have actually a much higher retentive force than compared to whenever we have the same material and an attachment with the gingival scallop. So again, it's usually sometimes even up to twice as much retention, which when we're dealing with clear aligners, that's the main thing that we want to be worried about. We want to make sure that those aligners have great attachment, because without attachment, we're not going to be able to move any teeth. Next, crowding. So how do we want that crowding to be fixed? If we want to use IPR, which is again the interproximal reduction, we want to make sure that we select how much we want to fix with our IPR, or how much we want to fix by moving those teeth. So IPR can be done up to 0.5 millimeters per tooth interproximally without damaging the enamel, without having any problems down the road. And we'll talk a little bit about that too. Next, overjet and overbite. Do we want to improve this, or we want to maintain this? That's pretty straightforward. Tooth size discrepancy. So either, again, this is going to be mainly done with interproximal reduction. If we don't want to have any tooth size movement, then we don't worry about this. This is something that can be mainly done whenever we're talking about restorative work, like with Lumineers or with crowns. If we have too much spacing and we actually know that we're going to restore that tooth, well, we can actually tell the lab, you know what, I want to have 1 millimeter between these teeth by the end of treatment, because they're going to be restored with either Lumineers or with crowns. Next, alignment. So do you want to go premolar to premolar, or do you want to go canine to canine? We're not going to be worried about the molars in this case, because again, the molars are going to be more complicated cases. These are pretty standard cases that can be done at pretty much any office. So the lab default of how much movement we can do is 0.25 millimeters per tooth. But we can go up to 0.5 millimeters. So that's just going to depend, again, on each case And if you don't choose anything right here, the lab is going to assume that you're going to want to move just 1/4 of a millimeter. Next, obviously, want to choose a case plan, which is a standard case, a flex case plan, or the mid-course correction. So the mid-course correction is something that can be changed after you have started with your case. If you want to do some different changes, then you can go ahead and also send that to the lab. Next, require patient photo. So this is just what we saw already. We want to make sure that we're sending the lab a profile at rest, the front smiling, the occlusals, and also the retracted. Okay, so after we have all these steps, after you have this form filled out, now we can actually use these initial records for our case submission. So the case submission can be done one of 3 ways. The first way is if we have the prescription form and we print it out, we can actually ship it directly to DenMat. That's the first way. Second way is if we have a scanner, then we can actually use that scanner and submit that case directly through the scanner to DenMat. Or the third way is if we have a scanner and we have the STL file saved, we can actually submit it through the online portal that DenMat has if we have an account at DenMat. So again, the easiest way is probably to just scan it and send it directly from the scanner. I know that there are still a lot of offices that are taking impressions, but honestly, the precision that you're gonna have whenever you're taking a scan is so much higher because it's gonna allow you to see any mistakes that you've made throughout the scan. So if you have some data that's not captured correctly, you're gonna be able to see that directly and immediately on that scanner. Okay, so after we talked about this, now let's talk about treatment plans. So what does the lab now get back to us? What do they give us so we can review? Well, we have that treatment plan. We're going to receive an email, and that email is going to have a link. So with that link and that token, we're going to be able to see our treatment plan with a 3D rendering of the treatment plan. So we click on this link, we put our token in, and we can see the whole treatment plan. So we can see how many aligners are going to be needed. We can see where the interproximal reduction is going to have to be done. We can see where the attachments are going to go. And we have to make sure that these are achievable results. So in order to check this, we want to go 1 through however many aligners we have. And we want to make sure that each step actually makes sense to us. If we want to have any corrections made, well, then we just write back in the note that please make these changes. Or if we're happy with it, then we can just go ahead and approve it directly, and then the lab will actually make us those clear aligners. So again, when we take a look at this email that we receive, we're gonna also have a PDF file. So this PDF file is going to have all the data of that treatment plan, but it's gonna have exactly where those attachments are gonna be and what the proposed treatment is or proposed design is going to look like. So we can see that this patient had some crowding. So we see she has crowding in the top and in the bottom. That's the initial position, and we're going to be moving to the final position, which we have much straighter teeth. But what do we need to do to accomplish this? Is this something that can be accomplished? Well, let's take a look at the PDF that was sent to us, and we can see that those red lines are actually where we're going to be making, or we're going to be doing some interproximal reduction. So those interproximal reduction actually tells us exactly at what stage or at what number of aligner we're going to be doing it. So we can see that between 27 and 28, we have 0.5 millimeters reduction, but that's going to be done at stage 1, as opposed to all the other interproximals that are actually done at stage 14. So when we're at stage 14, which is the number of trays that we're going to get to, that's when we do those interproximal reductions. Now the attachment, which is that little blue dots, that's going to be done at the first visit. So if we follow this treatment plan, we're going to have those final results very predictably. Okay, so next, let's talk about aligner manufacturing. So after we approve that treatment plan, we send that to the lab, and now the lab can actually make us our aligners. So this is probably the most important part after your treatment plan, because it doesn't matter what you're treatment planning or what you're treatment planning or what you want to achieve. if you're not using the right materials. So something that's very unique with DenMat, and very few actually manufacturers here in the US have it, is actually the 510 FDA clearance. That they're made in the USA. So what this translates to is that we're going to have very high quality. So most of the aligners that are out there actually don't have FDA clearance, and even some that do have FDA clearance, they're not manufactured here locally or domestically in the US. They're actually shipped out. So there's a dramatic drop in quality when something is not when we don't pay attention to all these small details that at the end of the day can make a huge difference in the treatment of your patient. So this is something that's definitely something important and to take into consideration. So next we have the delivery. So after the patient, after we have the patient come in for delivery, we really don't just give them the aligners and tell them, all right, you know what, we'll see you in 6 months and see what happened. We actually have to have some steps. So depending on each case, we can have some interproximal reduction whenever we have crowding. We might have to do some attachment placement. And obviously we want to make sure that we talk to the patient and give them instructions. The main instruction that we need to give to our patients is that make sure that they wear them at least 22 hours every day. Obviously, I tell them wear it at least 24 hours every day. Only take it off to eat, because patient compliance is going to be key in order to have a successful treatment. So let's talk about interproximal reduction. We saw that this PDF showed us exactly where we wanted to reduce it, but what does that mean, and what do we do? What do we use for interproximal reduction? Well, we have these tools, and all of these work great. I prefer actually to use the oscillating discs, which is going to be that fourth one, or just a regular disc, just because it's a lot faster and it's actually very accurate. If you're starting out and you're afraid that you're going to take off too much tooth structure, then there's also those interproximal reductors that we see on the left side, that yellow one, that's actually measured to see how much you can take off. It's the only difference with this one is just going to take a little bit longer. It's a little bit more tedious, but it's definitely something that's achievable. When we're done with interproximal reduction, we want to make sure that we're using these gauges to see how much reduction we've done. Again, we can do up to 0.5 millimeters of reduction on a tooth without damaging the enamel, without causing any problems to that tooth. So again, don't be scared of removing any excess that we might have to remove in order to give us some great tooth movement. Okay, so attachments. Attachments after interproximal reduction is done is what's going to help us hold those teeth together, those attachments, those clear aligners to the tooth. So this is just a straightforward bonding process where we etch the tooth wherever it is that we're gonna place those attachments. We bond the tooth, then we photo cure it. We're gonna place our composite in this attachment guide that's actually going to be sent to us with our ortho clear aligners, and we're going to lacquer again, and we have our attachments completed. So now we can actually take our clear aligners and be able to move those teeth. So why ortho clear? Why not another brand? Why not make my own in the office? Well, first of all, what is it made out of? So ortho clear aligners are made of a multi-layer polyurethane material that's actually very thin but super strong. So even though it's thin, it's flexible enough to where it's going to click into our teeth, but it's strong enough to where it's actually going to be moving teeth. So not just plastic that's going to go in and not do anything to our teeth. So it's going to move those teeth. It's not going to stain and it's not going to crack. Again, quality assurance. We just talked about this, about how important it is to have that FDA clearance, how important it is that they're actually manufactured here in California in the US. So it's just going to have quality. Next, we have that virtual treatment plan. So we're going to be able to see from start to finish what we can expect and what we can offer our patient, how long this is going to take, how many aligners are going to be needed. And obviously competitive pricing. I mean, the standard case, like you saw in my email, it's $795 and it's up to 30 aligners. So again, it's definitely something that we need to take a look at. And whenever we're talking about clear aligner therapy, I mean, we want to make sure that we're using something that's affordable to our patients, but it's also something that's going to be profitable to our practice. So by choosing OrthoClear, I think we can definitely take care of both. So just two more cases that I'm going to show you real quick of just simple movements that were done. So this is just a standard case, again, with a little bit of crowding in the back and some spacing in the front. We were able to close the diastema fairly quickly and fairly predictably. We have this other patient, again, that had just some misalignment that was fixed, again, with clear aligners. Again, simple cases that can be done that have a great result. So something that's so simple as that, just aligning the teeth a little bit can actually make a dramatic impression. So you can see the before, a selfie of this patient, and then the after, where we have nice clear teeth. We also used a little bit of laser gingivectomy to ensure that we have a little bit of a better pink to white aesthetics there. But again, so these are all just cases that can be done predictably whenever you're doing the right treatment plan, whenever you have people on the other side of the treatment plan that actually know what they're doing, that they understand clear aligners, and that they're using high quality materials. So I just want to thank everyone for joining us. Again, I know we're running a little bit long. I do want to leave a little bit of time to answer any questions that you guys might have. The best way to communicate with me probably would be through Instagram. Send me a message. If not, if you don't have Instagram, you can also email me at 87madrigal@gmail.com.